That's our psoas muscles, our psoas major muscles. Now, those arrows right there, can you see what I'm talking about? See how they look like little diagonal streaks? Y'all see what I'm talking about? Those are your psoas muscles. They look like little diagonal streaks going through the abdominal area, specifically in this area next to the L spine on both sides. So we have the left psoas muscles, we have the right psoas muscles. They will primarily be found in this area right here where the arrows are. We will not see them down here typically. Even though the diagram shows them going lower, we will see them right up here on a radiograph. Sometimes they're more prominent than others on different patients. Sometimes we can't see them at all, especially if it's a more obese type patient. But that is one of those main pieces of anatomy that we have to label on our KUB x-rays. Now, as far as the pelvis goes, there are a million landmarks on the pelvis. We're going to learn this all next semester. So you can breathe a sigh of relief. There's about 30 landmarks on this structure right here, but that's next semester. There are a couple of major ones I do want you to go ahead and make note of, though. Case point, the iliac crest. Y'all heard us talk about iliac crest? That's our major palpation landmark for KUB, so make sure that we center to the belly properly. Iliac crest is the top portion of the pelvis. Not down here, by the way, it's something different. This portion right here, the very top. That's going to be important when we palpate that we do that correctly. We're going to practice that in class if we have time today, or at the beginning of class on Wednesday, how to palpate on each other. Because if you can't palpate the crest properly, you will always center too low or too high. You've got to palpate those crests, and you're going to start doing what I call cup the crests. You got to cup the crest with your hand and get your hand and dig in there on the patient's side to find that properly. Another area I want you to go ahead and write down is this portion right here. This is called the ala of the pelvis. It's this major portion right here on the front, the ala. And then this one right here is what we call the pubic symphysis. Very vital because we check to see if we've centered properly for a KUB, if we can see the pubic symphysis on the radiograph. If this is cut off, we have centered too high. We must include pubic symphysis on every KUB radiograph. That's part of the evaluation criteria. Does anybody know the name of those two holes there, by the way? Because those are important too. See little holes right there? You're close. Obturator foramina. Obturator foramina. I always say, you know, imagine the pelvis kind of like a mask. Put it over your head. That's little eye holes down there. Kind of like a Mardi Gras mask. You don't see it? Now you'll never unsee it, right? Digestive tract. When we talk about the digestive tract, the main digestive tract is 1 through 6 on this diagram. Now, a lot of people forget that digestion starts in the oral cavity in your mouth. A lot of people say, oh, it just starts in the esophagus when I swallow. No, digestion begins when you put food in your mouth, you begin to chew the food, and your saliva mixes and churns that food. So digestion begins in the oral cavity. We swallow, it goes down the pharynx, then down the esophagus. By the way, what is the name of that rhythmic contraction of muscles that pushes food from the esophagus to the stomach?
Peristalsis.
Peristalsis, correct. That's a test question. Peristalsis. Now, from the esophagus, the food is going to go into the stomach, and of course, our small intestines, our large intestines, and then we're going to eliminate the fecal matter in the bathroom. Now, there are 4 other organs to make note of here. We have what's called accessory organs. They are what helps aid digestion process. It's our liver, our gallbladder, our pancreas, and our spleen. So main digestive tract is 1 through 6. The 4 accessory organs are your liver, your gallbladder, your pancreas, and your spleen.
Oh, question. So,
Yeah.
not related to this. For the people who are absent today, do you send them the slides?
I do not know.
So they should be missing out.
Yes.
Did you say accessory organs are liver, gallbladder, pancreas, and spleen?
Correct. They aid with digestion. Aid the digestion process.
And those are your accessory organs.
That's our accessory organs. All right, so you guys remember this back from chapter 1 and 2, the abdominopelvic cavity. So remember that abdominopelvic cavity, it extends from our diaphragm all the way down to the bony pelvis. And we have 2 subsections of that abdominopelvic cavity. We have the abdominal cavity and the pelvic cavity. Those are both subsections of the overall abdominopelvic cavity. Abdominal cavity is the larger of the two. It contains most of those organs. Pelvic is going to be mainly for your rectum and your bladder. Of course, we're going to break down those organs specifically here as we move forward as well, on little parts of it. All right, so what does that abdominopelvic contain as a whole? Now, there are more organs, there's veins, there's arteries, a lot more found in that cavity, but these are the main ones I want you to focus on for now. That's going to be our stomach, our small intestines, our large intestines, our liver, our gallbladder, our spleen, pancreas, and our kidneys. That's our main organs we're focused upon on this chapter of what's contained within the abdominopelvic cavity. Now, as you look here, you can see there's a lot of little labeling on those intestines. Do I need to know all these? Yes, you do. We're going to look at those closer moving forward. Intestines specifically. Liver we're not so concerned with right now. We're going to come back to that in Rad Pro 4. Stomach and spleen we're also going to come back in Rad Pro 4. We're going to focus on our large and small intestines because we can see those specific parts on most of our KUB radiographs if there's air or contrast in the patient's organs. Anybody ever have their appendix removed?
Mm-hmm.
Some of you have?
Oh no, I heard of it. My mom.
You know, they discovered that's not, they used to say that was a vestigial organ that we didn't need. It actually has a use, it's actually part of your immune system. We actually do need our appendix. Helps with immunity.
My mom swears that she ate Church's chicken and then she had to go get her appendix removed.
From Church's chicken.
So now she doesn't eat Church's chicken.
I like Church's chicken too.
I like it too. I like her mashed. That's pretty cheesy.
So the line where the urinary bladder is, those two little tubes that's on the side of that.
What are you saying?
Those two little, like, so you see the urinary bladder's right there, right? If you had to show me on there, where would be the ureter?
The ureters?
Mm-hmm.
The ureters go up both sides like this.
Okay.
To your kidneys, which are about this level.
Yeah.
Then urethra is what you
I
actually
just
urinate
wonder
out
what
of.
that looks like because you know mine was separate. So I
Oh,
wanna
it's
see
right.
what it looked like,
Right,
yeah.
right.
And it was separate from the urinary bladder.
Right. We're gonna hit that very specifically in Rad Pro 4.
Mhm.
We can do studies to evaluate all that. Pelvic cavity, that subsection, guys. What's in that pelvic cavity? Specifically, we have our rectum and sigmoid. Sigmoid's another portion of the colon, by the way. Sigmoid is this area right here, and rectum is right here. And then your urinary bladder and your reproductive organs also fall into the pelvic cavity. That subsection of the abdominopelvic cavity. So you can already kind of imagine yourself some multi-choice questions here that we just did. So easy way to memorize that, guys. Memorize those four, pelvic. Everything else goes in this one. See how I did that?
Mm-hmm.
And of course, if it looks like respiratory organs, that's obviously not going to apply either. All right, so systems in the abdomen, we have different organ systems. The primary three systems that are going to be in there are our digestive, urinary, and reproductive. Of course, for this chapter, we're going to focus on digestive primarily and come back to that urinary and reproductive systems in Rad Pro 4. But our abdomen does contain those three main organ systems with some overlap with others like your cardiovascular, your endocrine, things like that as well. Anyone ever had a kidney stone? I'm told that's like worse than childbirth.
They thought that I would start having them, but thank God I haven't.
So a kidney stone, if you imagine, it's literally like a little stone of minerals, and it has these little sharp shards on it. So when your kidney passes it, It's going down your ureters, and that shard is like tearing at the walls of your ureters. And it sits in your bladder for a while, and if it's not eliminated, it's going to tear at your urethra as you pass it as well. So they say it's like worse than childbirth, one of the worst pains on the face of the earth.
Does the urethra reconstruct itself, or?
I mean, it can repair itself, but it's going to cause you a lot of pain.
Those gallstones hurt too.
Yes, yes. All right, portions of the small intestine. We have 3. Gold star, because they love to ask these 3 portions of the small intestine. We have the duodenum. Now, this is not in your book, by the way. It's a different picture. You want to take a picture of that? But we have the duodenum. That is the first portion of the small intestine. As your stomach dumps food into the small intestine, the first portion it dumps it into is the duodenum. Important to make note of, because that's the shortest and widest portion of the small intestine. The second portion of the small intestine in the path of digestion is what's called the jejunum, followed by the final portion called the ileum. And the ileum is the longest portion of the small intestine. Duodenum is the shortest and the widest. Ileum is the longest portion. Jejunum is stuck in the middle. So duodenum, jejunum, ileum is the path of digestion to the small intestine. Now, if you want to go ahead and write this down, when your food gets to the ileum, it begins dumping into the large intestine. It does this by way of what we call the ileocecal valve. The ileocecal valve receives the food into the large intestine, and that first portion of the large intestine, which we're about to review, is called the cecum. C-E-C-U-M, cecum. And we can actually see all this on a radiograph if they've had contrast. You'll be able to make out these different portions. When it comes to labeling, your duodenum will always be labeled close to the stomach. Jejunum will always be the top left portion over here. Ileum will be the bottom right portion over here. I'll show you on a radiograph what I'm talking about.
Can you repeat the order, like how it goes through?
Sure, so from the stomach, the food is going to dump into the duodenum. That's the shortest and widest portion of the small intestine. Travel through the jejunum, and finally it's going to reach the ileum, which is the longest portion, before it dumps into the cecum of the large intestine through the ileocecal valve. Every portion of what I just said there are test questions I've seen. I'd love to ask those.
You said stomach to jejunum.
Stomach to duodenum.
Duodenum.
This is without
Duodenum.
And there's cecum at the end.
Cecum is the first portion of the large intestine.
No, whatever you said is basically that order. Stomach.
It says the order,
Yeah, the
yes.
duodenum,
So far.
jejunum,
Stomach,
and
duodenum,
ileum.
jejunum, ileum. And it dumps into our large intestine.
Okay.
If you've never seen intestines, they actually do look very similar to that. You'll see some surgeries where they're pulling intestines out. Pretty cool to see. All right, large intestine is going to have the most anatomy of this chapter right here, guys. I went ahead and listed them for you, but we're going to put them in order. We're going to look at them on a diagram here moving forward. So, of the large intestine, we have, of course, the anus, the appendix, sometimes called the vermiform appendix. Our ascending colon, our cecum. This is in alphabetical order, by the way. This is not the order of digestion. Descending colon, that ileocecal valve I just told you about. You have your left colic, sometimes called the splenic flexure. The rectum, the right colic, sometimes called the hepatic flexure, and your sigmoid and your transverse colon. Now, a lot of these are named according to the direction the food moves, and I'm going to show you on a diagram what we're talking about here. It's not as difficult as it looks. But this is going to be the largest portion of anatomy for this chapter right here. The main things we got to memorize.
How do you say that last? Ileo what?
This ileocecal valve. So, and it makes sense because that's where the anatomy is connecting. You have your ileum of the small intestine dumping food into the cecum. So, see the word ileocecal, ileum cecum, ileocecal valve.
What's the part that's cut off? The left.
Oh, it's flexure. sorry, flexure. Flexures are the top two corners of our intestines. And someone stole our model, because I was going to show you guys on the model. Someone took our model. I bet you someone kidnapped it. Let's go kidnap it back.
Oh, you guys went to.
We didn't take it with us, no.
Oh, I thought that was
Question?
the
So
minion.
is that a continuation from after the ileocecal valve?
This is just a listing of the large intestine landmarks. This is not the order. It's just all the ones we're going to label.
Also,
here in a
these are
second.
the part of the large
Correct. It's
intestine.
just alphabetical order here. I think my next slide has it all labeled in order.
Do we have to know splenic and hepatic?
So yes, that's alternative names for those flexures. I'll explain why they're labeled as such on the next slide here. This next slide is not your book. It's another really good diagram if you want to take a picture of it. This is basically the order of that digestion once again. So let's start at the top. This is all the anatomy we just named on that slide, including the small intestine. Although they're not labeled, we're going to go ahead and go through the small intestine and just follow our path of digestion. Let's start at the esophagus. Let's start at the very beginning. We're going to chew our food in the oral cavity. We're going to swallow it. It's going to go down our pharynx to our esophagus. At that point, it's going to push it down with those contractions called what? Peristalsis to the stomach. It's going to sit there for a while. After it's been digested, it's going to move into our duodenum, which that was the shortest and widest portion of the small intestine. That's about right here. It's going to flow into our jejunum, this portion of the small intestine, down to our ileum. That's the last portion of the small intestine, also the longest portion. Then it's going to dump into the large intestine via that valve we just talked about, the ileocecal valve. It's the termination of the small intestine and the beginning of the large intestine. Let's say it again. The ileocecal valve is the termination of the small intestine and the beginning of the large intestine. It dumps into the cecum, the first portion of the large intestine. Now, the food is going to travel in this path right here. We're going to move up first. So guess what the first portion is called? The ascending colon. What's ascending mean? It moves up. We're going to ascend up to our first corner that we call the right colic flexure. Anatomical position once again. Right colic flexure, also called the hepatic flexure. Why is that called hepatic flexure? That's a fancy way of saying liver. The hepatic system is the liver system. So it's our right colic or hepatic flexure. Then we're going to move horizontally or transversely. Transverse colon. Y'all see that? Ascend, transverse. To our next flexure, the left colic or the splenic flexure. Why is it called splenic?
Spleen.
It's right under the spleen. Then we're going to move down. What's another word for down? Descending colon. This one, they decided to get funny with it. Sigmoid colon. And then, of course, our rectum, and then the anus where it exits into the toilet. And you flush it away. So that's our path of large intestine digestion.
Does
Question?
it go into the cecum first and then ascending?
It goes to the cecum first, and then it ascends, correct. It collects the cecum, moves up, across, down, and out. Really great diagram. I take a picture of that because that really gives you a nice order of that digestion. All these parts we can see once again on a radiograph, whether there's air or contrast in that colon. By the way, the words large intestine and colon can be used interchangeably a lot. You'll hear some people say colon, some people say large intestine. That's referring to the same general area. Large intestine / colon. Yes?
Can you repeat that? The ileocecal valve is the beginning of large intestine?
Ileocecal valve is where the small intestine terminates and the large intestine begins because it's dumping that contents into the cecum. That's this area right here. Because the ileum is the last portion of the small intestine. It dumps into the cecum and begins moving up and out. Once your large intestine doing it, it's absorbing a lot of the last bits of fluid out of your food that you digested. So it makes fecal matter more solid, and then we eliminate it. So we get the last of that water out.
So what role does the appendix play?
Appendix is for immunity, for the immune system. It's a more recent discovery. I used to think it was a vestigial, useless organ. It actually aids in immunity.
Like the gallbladder?
Yeah, part of the same system, yeah.
Excuse me, sir.
Mm-hmm.
So what does flexure mean?
Flexure just means corner. That's the
Oh.
top two corners of the large intestine. And whenever you do barium enemas, you're going to insert your tip right here, and it's going to do a reverse action and fill that colon up with contrast. For barium enemas, that's that specialized study we do to look at the colon on X-rays. The one that I got sprayed on.
So where does that one stop?
Huh?
Where does that one stop?
Where does what stop?
When you put like
Placebo?
through your anus, does it go?
Oh, where's the tip stop? Well, I mean, some people push it way too far, but generally about right here, close to the sigmoid. You don't want to push further because you can actually rupture the wall of the large intestine if you get too aggressive with it.
How do you know does it like stop by itself?
How do you know? There's a little line on there that shows you where you shouldn't go past. On the little tip, there's a little raised line on it, and if you go past that, you're in danger of hurting the patient. You don't want to go beyond that. You got to be careful because anyone ever done suppositories before? We're getting a little personal here, but what's the colon do? It suctions. It suctions. So you got to be careful because they will suction up that tip as well. So you don't want to go too far. That's why people who have foreign bodies stuck up there, they stuck the foreign body too far, and the colon suctioned it up into the large intestine. They can't get it back out. Which happens, you would not believe how many times that happens. Oh, that leads me to another story. Right on time.
You said you were going to give us a story on Monday.
Yeah, I
you
did.
did. Yeah, you did.
All right, well, let me go through this slide, and while you write this down, I'll tell the story. We have some different classifications of that cavity. Once again, guys, we have what's called the peritoneum, the peritoneal cavity, and the retroperitoneum. Basically, you just need to know what's found within each of these cavities. Peritoneum is a double-walled membrane sac that encloses the entire cavity. So it's like a protective covering over the whole abdominal cavity. We have an inner versus outer layer. The inner is called the visceral peritoneum, and the outer is called the parietal peritoneum. Then we have what's called the peritoneal folds, also called the mesentery and the omenta. When you cut through the abdomen, there's a bunch of yellow tissue. That's called the mesentery. That's what's holding the organs up. If that mesentery was not there, our organs would basically just fall out of our body. It's like an attachment point to hold the organs up in our abdomen, and also to provide like nutrients, blood, things like that to those organs to keep them alive. So there's support. Support is their main function. The peritoneal cavity is the specific space between those two layers of peritoneum we just discussed. Peritoneal cavity, it contains what we call serous fluid. And then finally, the retroperitoneum is the space behind the peritoneum. That's the posterior portion of the abdomen back here, and that's where your kidneys and your pancreas lie. Kidneys and your pancreas. So talking about foreign bodies, I swear most of this stuff seemed to happen my first semester as an X-ray student. We were doing some KUVs on a patient, some abdominal X-rays, and we printed the X-rays, or they came up on the screen, and we noticed that there was a foreign body in his rectum. It looked like a big bottle. So it looked like a bottle of liquid in it, first of all, as well. You can see the liquid in it too. And they went to interrogate the patient because they said, hey, we need to know what's going on here, sir. You need to tell us what happened, how that get in there, what is it? And he said, oh, it's a shampoo bottle. And
Like in the rectum?
yes, it was lodged in the rectum. It suctioned way up into the large intestine. It was a shampoo bottle. And they said, well, sir, how did it get there? He's like, well, you know, I fell on it in the shower. And he was just being really shady. They're like, sir, we need you to tell us what happened because we may need to do surgery to get this out. It's very far inside your large intestine. Well, then he said, no, he was sleeping and his friend put it in there. And then he finally admitted that he had put it in himself. And everyone always wants to act like it was an accident. You'll see what I mean. Get to clinic next month. But usually it's caused by them doing their thing and not doing it safely. Anyway, they had to actually go in and cut this guy open because it had shot so far up the large intestine that it was internally lodged and they could not suction it out. They could not get it out with forceps or anything. They had to cut him open on the side and actually remove it from the descending colon. It was up in the descending colon. And I remember the surgeons came back, they put in the report, yeah, we found the shampoo bottle, it was purple, it was a bottle of Nexum shampoo. I never used Nexum shampoo, probably shouldn't now. It was a bottle of Nexum shampoo, and they confirmed it was a shampoo bottle. But I used to have copies of those x-rays, and they have since deteriorated because it was actually on real film, and x-ray film does not last forever. That was like a million years ago, and the images have deteriorated, but I wish I could show those to you because you can see it clearly. It's a wide bottle. Like, it's not a skinny bottle, it's a wide bottle of shampoo. It's huge. But you'll see what I mean when you get to clinic. People do a lot of insertions and it gets suctioned up in there, and they have to usually surgically remove those because once the large intestine suctions onto something, it's really hard to get it out. So, yeah.
Professor, why suction in the...
Why suction? Just I don't know the exact logistics behind that, but the large intestine does. That's why you do suppositories rectally, because the large intestine will suction things up in reverse. I'd have to get back to you on that. That's how it works.
If that shampoo bottle like popped open and leaked inside his body, would you have passed through?
What's that?
If that shampoo bottle popped or leaked inside?
Probably would have caused some problems, yeah. I saw one with a beer bottle before too. A beer bottle. Yeah, and it still had the beer in it too. I've seen kids' toys. I've seen stuff you don't really want to know about. I've seen just about everything.
But those people
And
are
you will
like on
too.
drugs, right?
Huh?
Those people are like on drugs
No.
and stuff?
There's just weird people.
They're just for you.
I'll leave it at that. All right, don't forget our body habituses as well, guys. That is not going away. We have our normals, our extremes, guys. Remember, are these our normals or extremes right here?
Normal.
These are our normals or averages, sthenic versus hyposthenic. But look at the difference on the intestines in particular, how extreme the differences are. Normal patient, there's your average diagram that we just looked over, but look when we just go to hyposthenic, how the organs begin to fall down. Does this cause issues? It does not. It's just how those organs are going to lie on those body habituses. Then your two extremes, your asthenic and hypersthenic. Look how low these organs are. This is your super skinny patients. The stomach, look how low the stomach is. It's down in the pelvis. And this actually looks like this on our x-rays. In fluoro, look at the intestines. It's like they're falling out of the body. But that's normal. It's just how they hang on that body habitus. Versus your other extreme, your hypersthenic, they're going to become very wide. So these are the ones, this is like the one that made the mess on me. She was hypersthenic. We had to do quadrant x-rays because she was so wide. So we had to do an x-ray here, 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 here to get all the abdomen on there. So, not abnormal. Don't freak out like, oh my God, their organs are falling out. It's totally normal right there. Although some people's organs do fall out. That's another issue. But it happens with a lot of elderly women, like prolapse and things like that. So you'll see things like that happen where those, like that mesentery and those attachment fibers begin to deteriorate and the organs literally start falling out of the body. You probably have had relatives have had that repaired before. My grandma had that repaired. Nobody? I'm the only one? Okay. But that is a common issue with a lot of elderly people. Their organs, the attachments become loose and those organs will actually start falling out of the body. Topographic landmarks. So we have lots of them in the abdomen. Of course, the main star of our show is the iliac crest. If you're going to memorize anything, here's what your registry is going to definitely ask you. What level does the iliac crest fall at in relation to the spine? L4, L5 on average. There's that xiphoid process again, T9 to T10, and the inferior costal margin L2 to L3. Of these three right here, which one do you think is the least, or which one should you probably not use as a palpation point?
Oh.
This one right here, that's the ribs. Having ticklish people? If you poke right there, you're going to be getting people giggling all over the place. Don't poke the ribs. Use that crest, although people get ticklish there as well. But that's three of the palpation marks that we're reviewing here. We got a few more towards the bottom as well that we can use. We use these for positioning of the abdomen. You guys will start practicing that tomorrow and Thursday in lab. And really quickly, before we run out of time here, I want to do a demonstration. Do I have a volunteer that does not mind having their waist poked? All right, your hand went up first. Come lay on the table back here. Do you mind if people palpate your crest? Okay. I want everyone to get hands-on. This is where we're going to stop today, by the way. a hands-on at popping the crest, so you can show off to Mr. Fong tomorrow and Thursday. So patient, if you will lie down.